actually examining the nose, you were mentioning that part of your interest in becoming a rhinologist is because traditionally our teaching has been so fragmented about best, and I can't ever remember being taught how to examine a nose. And other GPs are probably like me and use their otoscope and then think, well, it always looks like a mess up there. So could you give us a bit of advice about, if you were stuck just with your otoscope as someone who's really good looking at noses, what's the best way to do it?
Look, I guess in this discussion, it's picking out rhinitis from other conditions. And so I think if you examine a nose in a patient who has nasal congestion or mucus, it's highly likely it's not going to look normal. There's going to be something going on. And a variety of conditions will produce vasodilatation or congestion in the nose. So when you look in the nose, it just looks like everything's congested. And one of the best things, it's maybe a bit red because the respiratory mucosa, once again, is not like skin. It's only a thin layer, and you can see the blood vessels underneath. So spraying the nose with a decongestant spray makes a lot of sense because it gives you a chance to put your otoscope in. It's not because you're spraying it to make it necessarily more comfortable for the patient, but which it is. It's so that you can actually open up the nose and have a look in and see what's going on.
And maybe demonstrate to them.
If there's no pus in the middle meatus, there's no polyps existing there's nothing else happening, but it's only purely a rhinitis or nasal cavity reaction that appears to be going on. Give you a lot of confidence to say that this is what you're treating, nothing else.
Because patients, usually tip their head back for us to insert the otoscope. It's, we're actually just sort of looking at the turbinates. Is there a positioning thing you could suggest?
Do it like you do it in an ear. So when you hold the scope, hold it like a pen, and then rest your hand against their cheek or their maxilla, so that even if they do buck, especially children, it means that your hand's going to move with their head, and you're not going to accidentally poke the otoscope onto the mucosa, which is what we teach, of course, when you look at ears. One of the most dangerous positions in an ear is to sort of hold the otoscope and look in. You always want to brace your hand that has the otoscope against some part of the patient's head. So even if they move back and forth, your hand moves with the child, especially for children, with the child. Because you know that if you touch an otoscope onto the skin of the ear canal, it's very hard to regain the friendship after that. And the same is probably true for the nose.